Thank you. Now we'll come to the next talk, which is errors in OCT. I request Dr. Smita Narayanan to speak to us on errors in OCT.
Thank you, sir. Good morning, ladies and gentlemen. I shall be taking you through some printouts of OCT RNFL, and we shall discuss the pitfalls on the way. In my hospital, we have the Heidelberg, and so most of my printouts will be of the spectralis. Though I have tried to incorporate a few Cirrus printouts, but the basic principles are the same for any kind of machine. I shall be talking only about the OCT RNFL. I shall not be talking about the optic nerve head or the macula or the ASOCT. And another caveat, I would prefer that the OCTs are done after dilatation of the pupil, because that decreases the variability and brings about a better signal strength and quality. So before you start interpreting the printouts, you should know the minimum signal strength for each machine. For spectralis, it is more than 15, and for Cirrus, it is more than 6. For RTView, it is more than 30. So this is where the signal strength is given. This is where the signal strengths are given in the spectralis, and you can see that it is 31 in the right eye and 30 in the left eye, and that is pretty good for this machine. For the Cirrus, RNFL thickness measurement. Now, in this printout, you can see very clearly that the circle is exaggeratedly decentered. When this happens, you can see in the distant profile that the thickness and the contour both are abnormal, leading to red and yellow areas in the pie chart. But however, when this is corrected, when the center of the RNFL circle measurement circle and the disc coincide, you will see that the contour has now become normal, thickness has now become normal, and the pie charts have also become green. So decentration, if it is more than 10%, it should be looked at with caution. So you can see in this picture that this is decentered by about more than 10% in the nasal area, and so this is correspondingly yellow in the pie chart, and such a printout should be rather discarded. You know about the ISMT rule, and so you can imagine how the decentration superiorly can affect the RNFL OCT. After looking at the position, you also look at the area which is covered by the ray. So here you can see that there is a black area here. It is a floater. Similar to a floater, you can have peripapillary atrophy, or you can have myelinated nerve fibers which can prevent acquisition of the OCT. And so you can see here, correspondingly to this nasal area in the B-scan, you can see that there is no acquisition of scan and poor segmentation, which leads to this touching the x-axis. If the floater is outside, like this, outside the segmentation ring, it doesn't affect the acquisition of the scan. However, if the floater straddles the acquisition ring, then like this. However, if this floater is straddling like this, then it affects the acquisition of the scan. This is the Cirrus printout which I had shown previously with the in lesser signal strength. You can see in the thickness map, sorry I'm not good with the pointer. You can see in the thickness map that there is a black area which corresponds to the presence of this floater which is impinging on the RNFL measurement circle in the inferotemporal part, and so you can see there is a yellow borderline area shown in the pie chart. So this is how a floater affects the quality of the scan. There are nowadays motion artifacts are not seen with the new machines because they have sensors which prevent the acquisition of the scan. So a motion artifact will be seen as a horizontal area over here, which will show an interruption in the continuity of the blood vessel. You can see the blood vessel going up here, and then it has moved to this area. So this interruption is seen in the motion artifacts, and rather these scans should also be avoided. Cartridge artifacts are seen when you have student technicians, which usually happens in our hospital, and what happens is that the periphery of the scan is not clear, even though the center appears much better. So this usually should be discarded and another scan should be taken. In the Cirrus printout, the cartridge is seen as a black area in the thickness part, and you will see the supranormal measurements in the edges of the scan. Showing it, therefore these are shown in the white here. Now look at this printout. You will see, if you are only looking at the pie chart, you will see that there are certain areas which are shown in the red. If you look at the P-scan, you will see that there is almost a big failure of the segmentation, and when the scan was repeated, now the Tisnet profile is normal. You can see there is a normal contour and normal thickness. So this segmentation failure, when you see things touching the x-axis, it's better to go for a examination of the screen of the OCT machine rather than to look into the printout. PVDs and this epiretinal membranes, they cause increased thickness, and they pull up the RNFL, they cause increased thickness, and then they can also cause a failure in the measurement of the thickness because it is difficult to identify the anterior or the inner border of the RNFL. Further, when the PVDs progress, then you will find that it is difficult to find out which part is the RNFL and which part is the PVD because of the PVD, and thickness reduces when the PVDs progress. Posterior misidentification of the RNFL happens when there is an algorithm failure. You can see here there is a large blood vessel, and so there is a large dip in the posterior RNFL identification leading to a supra-thick. You can see it has crossed the normative database and supra-thick RNFL measurement. Floor effect should be known for most of the machines because in advanced glaucoma, the machine, there is actually what is happening is that the RNFL is nearly lost in the advanced glaucoma, and the cup of the optic disc contains the blood vessels and the some amount of glial tissue. So any measurement beyond 50 in the spectralis and anything about beyond 57 in the cirrus should be taken with caution. So in this picture, this is floor effect. So if it goes beyond this, as you see here, then you should take it with caution. You can't actually use OCT to assess advanced glaucoma. Like in this picture, this is not a correct picture. It should make you think that the scan has not been acquired properly. Now in this picture, if you can see, I'm not sure if you can see clearly, there is an RNFL defect here, which has been shown as a early nasal step. But however, when you look at the OCT RNFL, it is all in the green. It so happens that the OCT averages the RNFL thickness in a given sector, and sometimes even if there is a focal loss, it is not seen in the pie chart. So this is called green disease, where you feel that the patient has no disease when you see the OCT, but when you actually see the patient's fundus and the fields, you find that the patient has disease. In this spectralis printout, you can see in the left eye, there is this area where the patient's profile is touching the red. However, when you see the pie chart, it is all in the green. So this is again a situation where the OCT has failed to pick up a glaucoma. Now, red disease can happen in so many of these conditions where the OCT doesn't have the normative database, and then you should go for the macular scan for glaucoma to pick up this condition. Now, red disease are the situations where the patients are referred to us because perhaps not the ophthalmologist, the referring patient, doctor thinks that this patient has glaucoma, and that leads to a lot of distress to the patient, and then you will go for an unnecessary treatment and a lot of expenditure, perhaps medico-legal conditions. Now these are the normal RNFL thickness in Indian eyes, which is about 8 to 12 micrometers, lesser than the database. For our machines, it is the European database, and you are comparing with this. So there are possibilities that you can go into the red with these. Then you should also know about the split and the laterally shifted RNFL, which happens usually in the myope. This is the RNFL bundle over here, which is split into two. It's a normal anatomical variation, and that is why this portion is in the red. And you can see that this is shifted temporally in the inferior area, and that is why it is in the red. Otherwise, this is just a normal fundus. This is a hypoplastic disc, what sort of an inferior segmental hypoplasia, which leads to a red disease-like situation. So most of the studies show that about 35 to 50% of the scans contain a lot of errors. But if you go systematically, you can pick out most of the errors. The risk factors are a visual acuity less than 612 or the presence of cataract, advanced glaucoma, and even paradoxically an angle closure disease. So the take-home message is, never base your diagnosis solely on the OCT. Spend time examining the optic disc or the disc photo and try to correlate the findings on the OCT machine with those on the disc. And absolutely look for the signal strength and the artifacts. If you find all of these or any of these, please redo the scans. Thank you very much for your kind attention.